We'll move on to the next session. I invite the chairpersons for this talk, Dr. Sanjay Kumar, Dr. Venkat Krishnan Iyer, Dr. Dheeraj Bhattad, Dr. Pratibha Pagar, and Dr. Tehseen Petiwala.
Hello. Welcome to this session. This is going to be an important, again, facets of chronic liver disease. I invite Dr. Dong Joon Kim for taking us through the APASL Guidelines on Quality of Life and Palliative Care in Advanced Liver Disease. Dr. Kim.
Thank you, Chairman. Dear colleagues, since APASL guideline is not published yet, I will deliver talks on general scheme of palliative care in patients with advanced liver disease and brief summary of AASLD guidance. Backgrounds. Patients with cirrhosis have a median survival ranging from 2 years in decompensated cirrhosis to 12 years in compensated one. On average, patients with decompensated cirrhosis have 3 hospitalizations per person year. The reason for readmission is frequently unrelated to the prior admission, reflecting the unpredictable course of this illness. Over 70% of patients with ASLD die in hospitals, which is 25% higher than the average for all deaths. Despite this, proper provision of palliative care is suboptimally addressed. Rate of advanced care planning remain low. There has been a paradigm shift in the role of PC for patients with serious illnesses. This 2010 NEJM study for patients with metastatic lung cancer demonstrated early PC led to not only significant improvement in quality of life, but also longer survival. In this 2025 JCO paper, early concurrent PC and oncology care showed better 1-year survival than delayed concurrent care. As a whole, RCTs on integration of oncology and PC point to health gains, including improved survival and symptom control, reduced use of futile chemotherapy, and improved use of healthcare resources. Similarly, in non-cancer populations, such as patients with COPD, heart failure, ESRD, there is established evidence that PC is associated with better quality of life, less aggressive treatments at the end of life, lower cost of care, and better patient and caregiver outcomes. Full integration of hepatology and palliative care relies on specific knowledge and skills of the dualistic perspective of care. The liver-directed approach, which focuses on treating the disease, and host-directed approach, which focuses on the patient with the disease. To achieve these dual goals, it must be based on changes in professional cultures, priorities in healthcare. Today, there are limited guidelines or guidance statements to direct clinicians in the area of PC and advanced chronic liver disease. General scheme of palliative care and advanced care planning. Palliative care is defined as an approach that improves the quality of life for patients and their families facing with life-threatening illness, which prevents and relieves suffering. It needs to emphasize that PC is applicable early in the course of illness in conjunction with other therapies that are intended to prolong life, so-called the concept of parallel planning. Traditional dichotomized perception of hepatology care and palliative care is outlined in this figure. PC is equal to end of life. However, it is not in line with the present definition of PC, especially in terms applicable earlier in the disease trajectory. So, the two should be integrated and given in parallel as outlined below figure. The overall goal of PC is to improve the patient quality of life concurrent with the patient preferences, patient-centered perspective. It is especially important during the patient's last years of life. Thus, optimal symptom management and active involvement of patient and family throughout the care process are key components. PC management typically relies on a team, including physicians, nurses, chaplains, social workers, and other providers. WHO defines integrated health services that people get the care they need when they need it in ways that are user-friendly. Integration of health services may be defined at three levels: linkage, coordination, and full integration. However, the achievement of integration is not straightforward because two different cultures, the liver-centered and patient-centered, need to join for the standardized care pathways. These tables summarize similarities and differences between primary PC, specialty PC, hospice, and advanced care planning. Primary PC can be delivered by any medical professional, including hepatologist. Specialty PC is delivered by PC specialist. Hospice is end of care, focuses exclusively on comfort. It is different from palliative care. Advanced care planning, ACP, is a critical component of PC that involves the iterative and longitudinal process of shared decision-making, SDM, over the course of the illness trajectory in accordance with personal values and wishes. ACP is a proactive, ongoing, collaborative process of decision-making about healthcare preference, goals, and values. This table summarized ACP definitions. Advanced Directive, AD, is legal documents which only go into effect if the patient cannot communicate his or her own wishes. Living will is an AD that specifies the types of medical care acceptable versus unacceptable. Healthcare proxy is also referred to as durable POA, power of attorney for healthcare. AD is legally recognized but not legally binding, which means that healthcare providers and proxy will do their best to respect patient AD, but there may be circumstances in which they cannot follow patient wishes exactly. POST and MOST are medical orders for life-sustaining treatments. AD, healthcare proxy, POST are all parts of ACP. Guidelines and guidance. This is American Heart Association Statements for Decision-Making in Advanced Heart Failure, published in 2012. American Thoracic Society Policy Statements on PC, published in 2008. American Society of Nephrology Clinical Practice Guideline on Shared Decision-Making and Withdrawal from Dialysis, published in 2000. In 2022, AASLD Practice Guidance on Palliative Care, palliative care in patients with decompensated cirrhosis was published. And in 2021, AJ Clinical Practice Update on Palliative Care in Patients with Cirrhosis was published. In the AASLD guidance, it is emphasized that PC is applicable across the spectrum of cirrhosis, regardless of transplant eligibility. Although a common misconception, PC is not synonymous with hospice care. Despite a high symptom burden and challenges with predicting disease course and evidence to support the benefit of PC in patients with cirrhosis, comprehensive PC is carried out infrequently and very late in the course of disease. AASLD guidance statements are PC can be provided to patients with decompensated cirrhosis at any stage of their illness, irrespective of transplant candidacy. PC should be based on needs assessment instead of prognosis alone. PC can be delivered by any members of the care team, primary PC as well as specialty PC. PC does not preclude the delivery of disease-directed or even curative treatments. Hospice is different than PC. For advanced care planning, ideally, clinicians, hepatologists with a continuity relationship with the patient and an understanding of their prognosis should regularly engage in conversations regarding prognosis and goals of care. But these conversations often do not occur until the end of life for patients with ASLD. Insufficient and delayed discussions likely contribute to receipt of high-intensity end-of-life care. Goals of care discussions in patients with cirrhosis should be repeated at sentinel events, including admission before initiation of life-sustaining supporting therapies or new onset of cirrhosis-related complications and after determination of transplant eligibility. Guidance statement is ACP is an iterative process that should start with the diagnosis of cirrhosis and preferably occur before hepatic decompensation and loss of decision-making capacity. There are barriers to PC implementation in hepatology, including many of the symptoms are highly liver-specific and managed longitudinally by liver teams. This is different from oncology practice, in which PC teams frequently have a key role managing malignant pain syndrome throughout the disease course, and fluctuating disease trajectory and prognostic uncertainty, unrealistic hope of liver transplant, shortage of specialty PC providers, and inadequate hepatology training, which does not routinely include palliative care, scarcity of studies on palliative care in hepatology area. Also, there is misconception that PC is equivalent to hospice or end-of-life care, and misconception that PC cannot be delivered concurrently with curative or life-prolonging treatments such as liver transplant. PC is not synonymous with giving up on curative treatments, and misconception that PC should only be delivered to decompensated patients. In addition, most of hepatologists are so busy and there are competing demands for clinicians' time. The barriers are not confined to physicians. Cultural barriers and challenges also exist. Death and dying are often taboo subjects associated with considerable stigma for people who are dying and those close to them. Because death has become less common in our daily lives, it has become harder to consider our own mortality. AASLD guidance statements are patients with decompensated cirrhosis and their caregivers often have significant unmet, unrecognized PC needs. Evaluation for unmet PC needs should be considered for all patients. In patients with decompensated cirrhosis, disease-directed care such as transplantation does not preclude PC delivery. Given the shortage of specialty PC providers, hepatologic clinicians should play a central role in offering primary PC services to patients with cirrhosis. At present, the need for competence in PC is unmet at all levels of healthcare, which calls for increased educational effort. Certification in PC falls into three categories: basic, advanced, and specialist. Palliative medicine has been established as a specialty or a subspecialty in the different countries. I would like to touch on topics regarding how to implement an effective PC interventions for patients with ACLD and what to do. A growing body of evidence supports the integration of curative and palliative care together as such in other non-malignant conditions. The question is no longer whether patients benefit from PC, but rather how hepatology teams should provide it, how comprehensive PC teams need to be, and what is the minimum model for care delivery. In a study conducted from AASLD members, 84% agreed that not a PC specialist, but a hepatologist is the best person to provide and discuss ACP with patients with ACLD. So, hepatology associations are encouraged to support palliative care through the provision of educational resources such as CME or online educations. The ongoing PAL-LIVER trial is a comparative effectiveness study of hepatologist-led versus specialist-led PC for patients with ACLD. The primary hypothesis is that hepatologist-delivered PC will build upon an existing therapeutic relationship with patients and expert knowledge of liver disease, which allowing them to better integrate PC into hepatology care. PAL-LIVER Network partnered with edX platform experts to design a course to teach primary PC skills to hepatologists. The course was designed based on specific scenarios of ACLD such as transplant eligibility, acute episode of decompensation, etc. The fundamental principle is patient-centered care. To achieve this goal, recommendations encompass implement the routine use of patient-reported outcomes measures, PROMs, not physician-reported outcomes, and integrate shared decision-making and advanced care planning as a mandatory part of all standardized care pathways, and mandatory training of hepatology and palliative care to be supplemented by international and national accreditations. Limited PC resources means that hepatologists must be responsible for basic palliative care because they are best placed to support patients with ACLD. A proactive approach to concurrent parallel planning led by hepatologists, including both liver-directed and host-directed approaches, should help improve the situation for patients with ACLD. Future implications. To successfully weave the principles of PC into hepatology care requires substantial research, clinical innovation, culture change, and health policy advocacy. A critical first step is workforce training and programmatic development to support palliative care. There is a growing consensus that clinicians across all medical and surgical specialties need to develop core competencies in providing primary PC. Guidance statements are future workforce training is needed, and developing hepatology competencies in primary palliative care is a first step toward this goal. Policy changes such as funding and reimbursement can help to support patients with cirrhosis and their caregivers. In conclusion, the evidence has demonstrated that better integration of PC with hepatology services could enhance the quality of care for both patients and their caregivers. A concurrent parallel planning led by hepatologists, including both liver-directed and host-directed approaches, should be embedded within routine hepatology practice. However, several barriers are existing at present. Hepatology societies should consider the integration of PC into the management for patients with ACLD to ensure the same standard of care is delivered as has been done with other chronic diseases. We are in need of wisdom, courage, and dignity. Thank you for your attention.
Thank you, sir. You can take a seat. May I now call upon Dr. Dinesh Jyotimani. He is going to speak on a very relevant topic, mycobacterial infections, management in advanced liver disease. A very common problem in India. Tuberculosis is very high. Dr. Dinesh is the Director of Hepatology at the Reliance Institute and Medical Center, Chennai.
Sorry, I just want to take a second here. Just a quick change. The resident corner that's to be held now at 1 o'clock is going to be shifted to post lunch in Hall B. And I've been asked to inform that those who are going to be leaving us today, if you all are checking out, please do so before 1:30 p.m. Sorry and thank you.
Thank you, the organizing committee and Akash for this wonderful opportunity. As the chairperson said, why this is a very relevant topic at this point of time? Because we are seeing more and more patients with chronic liver disease due to lifestyle, either alcohol or fatty liver disease. And the tuberculosis is still very high in different parts of the world. So if you look at this meta-analysis, the pooled prevalence reported was almost 40%. This seems exorbitantly very high. But even if you consider these patients are at risk of acquiring tuberculosis, this is too much to handle in the community. This is in the general population. So if you club cirrhosis, which is increasing, and tuberculosis, which is on the high, so this Dutch study published more than 20 years ago looked at the prevalence of TB in cirrhosis, and they concluded tuberculosis is more 15 times higher in patients with liver cirrhosis, particularly if you are men over the age of 65. Not only that, your case fatality rate, your mortality is very high, almost 1/3 of them die. Why cirrhotic patients are at risk of tuberculosis? We know in cirrhosis there is dysregulated immune system. Our T cells are quite exhausted and unable to clear the bacterial infections. So this has been attributed even in tuberculosis. This study from Maharashtra actually looked at, it's not just cirrhosis as a risk factor. In addition, they looked at the etiology of liver disease. Compared to viral hepatitis, patients with alcohol-related liver cirrhosis at very high risk of acquiring tuberculosis infection actually. So if you are cirrhotic, if you are alcohol, if you are men over the age of 65, there is a very high percentage, high chance that you will acquire tuberculosis infection. What is interesting is it is not the conventional pulmonary tuberculosis we see in patients with cirrhosis. This study from PGI Chandigarh, they looked at the patients from cirrhotic patients with tuberculosis, and they found that over 70% of the patients have extrapulmonary tuberculosis, that is pleural, peritoneal, lymph node, abscess, etc., arthritis, etc. So it is not patients with liver cirrhosis have pulmonary tuberculosis, they are more likely to have extrapulmonary tuberculosis. Now here is the problem. How do we diagnose tuberculosis in patients with cirrhosis? Let us look at what are the tests available in the general population. So the MAN2 test has been there for a long time. This is only to look at the risk of exposure. The most relevant, reliable test is interferon gamma release assay, otherwise called IGRA, so which measures the interferon released by the T cells. The test is gold quantiferon, which is more or less established test. Either you can measure the interferon or the interferon releasing T cells, that is T-spot test. So for this you need a good immune system. So you need a functional T cells which is capable of releasing interferon. But the problem is in cirrhotic there is immune dysregulation. So you're not going to see a very reliable outcomes of these investigations. So when in this study they looked at the reliability of interferon gamma release assay, and they found that almost 1/4 of them, the results could not be interpreted. It was indeterminate. Even if you suspect TB, the results were not adequate enough to diagnose TB. What other tests we have? We commonly use adenosine deaminase tests in the pleural and ascitic fluid analysis. So this test, literature showed this test is not very useful because once again of the immune dysregulation. However, this study that's been published sort of 10 years ago, they compared cirrhosis with and without TB. If you look at here, those with no TB had ADA of 7. Those with in the background of cirrhosis with tuberculosis, the ADA was quite high. So this seemed to be a reasonably good test for diagnosing tuberculosis. And also what they compared is in patients with TB with or without cirrhosis. So if you don't have cirrhosis, it's 70, and if you have cirrhosis, it's 58. So more or less similar. So if you have TB in the ascitic fluid, ADA is one of the reliable tests to go for. Now, the most important discussion comes through. What are the drugs we have for treating tuberculosis? Now, we all are quite familiar. We have isoniazid, we have rifampicin, and pyrazinamide, ethambutol. These are the most first-line drugs we use. All bactericidal drugs are hepatotoxic. Okay, so isoniazid we have. And in the general population, hepatotoxicity is reported to be 0.6%. Rifampicin is also a bactericidal drug, very effective drug. Again, hepatotoxicity has been reported. It's idiosyncratic reaction. Whereas if you look at the pyrazinamide, it's a weak bactericidal drug, but it causes dose-dependent hepatotoxicity. So high dose is related to fatal hepatotoxicity in almost 15% of patients and may lead to acute liver failure. Ethambutol is liver safe, but it is bacteriostatic. And we have the second line of drugs, which are mostly bacteriostatic but less effective. So here is a problem here. We have patients with liver cirrhosis, we have patients with tuberculosis, but all the effective drugs are hepatotoxic. So what do we do? It is interesting to look at. INH causes idiosyncratic reaction, but rifampicin per se is less hepatotoxic compared to your pyrazinamide and INH. But if you add rifampicin to INH, your drug-induced liver injury rates are higher. The reason is this. INH is metabolized by two pathways, okay, N-acetyl transferase and amidase pathway. The hydrazine released is hepatotoxic. What rifampicin does is, we know rifampicin induces enzymes. So these enzymes are induced, leading to potentiating the INH toxicity. So the point to understand is, rifampicin per se is less hepatotoxic, but if you add with INH, it increases the INH toxicity. So here is the situation. If you have a normal liver function, okay, close to 1, if you say, let me show you. So if you have a normal liver function, if you start them on anti-tuberculous therapy, and if they develop drug-induced liver injury, there's high chance they will recover. In patients with compensated cirrhosis, where the liver function is a little compromised, you can still start bactericidal or little hepatotoxic drug, but once they develop early drug-induced liver injury, you may have to withdraw the drug, but sometimes it can be lethal. Patients with compromised, severely compromised liver function, if they have less than say 30%, if you give, or if they develop a drug-induced liver injury due to anti-tuberculous therapy, the chances of mortality is quite high. So the chance of recovery is very low in these patients. So therefore, this is the situation. You have a cirrhotic patient with various degree of severity of the illness, and you have a patient with diagnosed or suspected tuberculosis, and you have different anti-TB drugs with varying hepatotoxic profile. So based on the severity of your liver disease, you can either use 2 hepatotoxic drugs or 1 hepatotoxic drug or no hepatotoxic drug. Using most of the practice involves avoiding pyrazinamide in patients with liver cirrhosis. So let us talk about 2 scenarios. One, this is cirrhosis and antituberculous therapy. Sputum positive, aggressive disease, pulmonary tuberculosis, and one is extrapulmonary tuberculosis, where you diagnose by indirect evidence. So if you have, this is only a proposal because there are no guidelines. So if you have child's age cirrhosis, sputum positive, and extremely well compensated disease, so you can use 2 hepatotoxic drugs, but the 2 start using sequentially rather than 2 at the same time, because we need to know which is causing the trouble. If you have child B patient with sputum positive disease or pulmonary tuberculosis, you may get away with using rifampicin plus other drugs. I'm not talking about just rifampicin alone, plus the second line drugs. If you have child C cirrhosis, definitely no hepatotoxic drugs are recommended. You should go with completely second line drugs. So similarly, somebody with extrapulmonary tuberculosis, you can start with a single hepatotoxic drugs because you may end up treating them for a longer duration and start INH, but start with a low dose and step up. Whereas in child B cirrhosis, the extrapulmonary tuberculosis, you start rifampicin and then again start low dose and increase and see whether they tolerate, and then add the other drugs. Once again, in child C cirrhosis, no hepatotoxic drugs recommended. So how long do we give? So when I say hepatotoxic drug, these are bactericidal drugs. So if you're using 2 bactericidal drugs, the course can be shortened to 6 months, which we all are familiar with. If you're using 1 drug, then you need to give a longer duration. If you're using no bactericidal drugs or no hepatotoxic drugs in patients with cirrhosis, you need to give a longer duration of therapy. This is typically what we do in patients with cirrhosis diagnosed with tuberculosis. So how do we monitor? Usually the hepatotoxicity or the drug-induced liver injury occurs by 4 to 8 weeks. So the recommendation is every 2 weeks, you monitor the liver function test for a couple of months. If the ALT is less than 3 times upper limit normal, monitor them closely. It may resolve. If it's more than 3 times upper limit normal, or if they have jaundice, withhold, because most of the drugs are idiosyncratic reaction, and re-challenge once they normalized. If the ALT is more than 10 times upper limit normal, or the patient is increasingly jaundiced, the outcomes are very poor. So you need to stop the drug immediately and see how we can manage these patients. This is in cirrhotic. In general population, it's actually the 3. ALT is less than up to 5 times upper limit normal, you can still continue actually. So what happens if these patients slip into acute liver failure? So patients who have drug-induced acute liver failure related to antituberculous therapy should be managed like any other ALF as per the protocol. Supraurgent liver transplantation or living donor liver transplantation should be offered in patients who fulfill poor prognostic criteria, because you can always treat tuberculosis in the post-transplant phase where they have a good liver, and then they can tolerate the drugs better. So the point is, patients with tuberculosis who develop ATT-induced ALF should not be denied transplantation. The advantage of LDLT is if you withdraw the drug and then manage these patients medically, there may be a chance they can improve and you can defer transplantation in these patients. Last slide, it's about treatment of multi-drug resistant tuberculosis. There are a couple of drugs and it's in the Indian guidelines, but surprisingly it was sponsored by USAID, so I don't know how reliable these drugs are. Definitely it's been there in the Indian guidelines, but not studied in patients with liver disease. So Chairman, ladies and gentlemen, I would like to conclude saying TB is more common in patients with liver cirrhosis, particularly extrapulmonary tuberculosis, and the diagnosis can be challenging because of underlying immune dysfunction. Anti-TB drugs should be cautiously prescribed based on the hepatotoxicity profile of the drug as well as the liver disease or the cirrhosis severity. Tuberculosis is not a contraindication for liver transplantation in the setting of ALF. I use the word focal because sometimes you may have a completely disseminated tuberculosis where you may have to make the individualized decision for transplantation. Thank you very much.
I have one query, Dr.
Questions,
Jyoti. That part I did not get it. That child A in extrapulmonary TB, you just want INH, only single hepatotoxic drug, and that to lower dose and then increment.
No, it's not a single drug. I'm talking about
Multiple drugs, but not using rifampicin and INH in that setting. That's what I wanted.
If you have
Child A.
an aggressive disease, better to use 2 bactericidal drugs. If you have child's A cirrhosis, we will be in a better position to use those drugs and we can monitor them. If you start these drugs at the same time, you don't know which is causing the problem. So that's what I mean, but it's not monotherapy. I'm not talking about the monotherapy.
You mean to say you start with one drug and step up then?
Step up and add the second drug and see how things go. So
Start
that's
them
what I meant by that, yeah.
We have another case-based discussion, so we can do the questions right after that, if that's okay. Yeah, so I would like to thank the speakers as well as the chairpersons for joining us. We'll move on to the next part, which is an informative case-based discussion on white shadows on the X-ray, a clinical dilemma, which will be moderated by Dr. Rahul Pandit, who's a chairman of critical care at Reliance Foundation Hospital and at all other Reliance Foundation healthcare initiatives. I would also like to introduce our distinguished panelists, Dr. Arindam Kar, Dr. Sushil Bindru, Dr. Bhujang Pai, and Dr. Pramod Kumar.
Okay, we have only 2 panelists who have come across right now. Let's start up the program. I, at the outset, thank Akash and the Build 3.0 team for the kind invitation. Let's start up with the first case. We've got only 15 minutes to talk about it. First patient was a 70-year-old male who had acquired hemophilia. For his acquired hemophilia, received rituximab steroids. Presented to other hospital with shortness of breath. By day 6, his symptoms worsened, requiring him to have hospitalization. And then by day 5 of hospitalization, he was a non-invasive. Next day, he became more worse in terms of his hypoxemia, got ventilated. And this was his chest X-ray taken in our hospital after we retrieved him in our hospital. So, Dr. Pai, any thoughts on this X-ray? White shadows.
Yeah, so what you see on the plain film taken in the ICU as a portable film, you see diffuse widespread ill-defined opacities which is involving both lungs and involving right from the apex to the lower zone on either side. I can also see a small pneumothorax on the right side. There is no pneumo which I am seeing on the left. There is no pleural effusion. The frontal cardiac dimensions are normal. And I'm seeing a central internal jugular line, an endotracheal tube, and a ECMO, which has been placed.
So Dr. Pai has picked up the patient, is on ECMO, obviously. That was the reason why the patient was brought to our hospital. Sir, any thoughts on this X-ray? What would you think if this was a liver patient, for example? Patient who had a decompensated liver failure, has been in and out of hospital and presents with this kind of an hypoxia to our hospital or to your hospital. What would be the thoughts running in your mind looking at this chest X-ray?
Agree with the findings what Dr. Pai ensured. The differential comes again. First thing comes is ARDS, and followed by again he has pneumothorax. Again, could be due to the barotrauma related to the ventilation. And again, for ARDS, we do have multiple causes. Again, first thing comes to our mind is infection, hospital-acquired infections that can cause this kind of picture. Again, bacterial infections is the thing. Again, followed by the cardiac issues. Pulmonary edema also can mimic this kind of picture.
Sorry, I didn't get the last bit. What did you say there?
Pulmonary edema.
Pulmonary edema. Okay. Of course. So infectious versus non-infectious. We've got our pulmonologist walking in, Dr. Bindru. You've been hiding away. This is a chest X-ray for you to have a look. If you could just define. This patient came in with background history of acquired hemophilia, been immunosuppressed, given rituximab and steroids, and comes to you in your hospital with profound hypoxemia. Can you tell me what would be the possible differentials apart from infective and non-infective? And if it is infective, what kind of infection do you think of?
So you say, so he is receiving some immunosuppressive therapy, right?
That's right, rituximab and steroids.
And came with sudden onset of hypoxia.
Not sudden, 5 days history of shortness of breath, gradually worsened, requiring NIV and then intubated, now on ECMO.
So the X-ray is suggestive of is a bilateral interstitial shadows. There's no cardiomegaly, so it won't fit into the realm of pulmonary edema, and the shadows are going to the periphery of the lung. In case of pulmonary edema, you normally have shadows which are restricted to the medial 2/3 of the lung. Now, patient presenting with the onset of dyspnea on immunosuppressive therapy, the differential diagnosis with this type of picture will be interstitial shadows will be one PCP, pneumocystis carinii, or Urwicky pneumonia. The second will be a viral infection. CMV in these cases will be should be thought of, and atypical pneumonias, mainly the Legionella, because they are the ones which can cause these fulminant hypoxic failures in patients with immunosuppressive therapy. So these are the three differential diagnoses for me in this patient.
So if, yes, Dr. Pai, you want to add something?
Which he mentioned was, which I told you that you're seeing a pneumothorax on the right side.
Yes.
One of the first things you would think of is a barotrauma. The other thing in a situation like this where patient is immunocompromised, and we first look at a PCP infection, and one of them which can present in PCPs is a pneumothorax, because they can have small pneumatoceles or they may have small cysts in the lung, and that can be only confirmed if we have a HRCT of the chest.
So would you want your patient to have a bronch? Dr. Bindru is not involved yet. So would you like to have your patient a bronchoscopy done for this patient or no? And if yes, I would like both of you and Dr. Bindru to share what would be the investigation. PCP, of course, it's coming out as a common theme, and I will come to what the patient had in the next slide.
First, again, if patient is stable enough to shift to CT scan, first we'll get a HRCT scan done, and again we'll do cardiac echo to rule out other causes. Third thing is, again, for diagnostic purposes, the bronchoscopy is the one, and bronchial lavage and subjecting for the various tests can identify the diagnosis.
So Shil, what would you ask on a bronchoscopy? What investigations?
So for this patient, I will, because we have a pneumothorax seeing, we are able to see, we are seeing bilateral interstitial shadows. So I'm not very sure what CT scan will add on to this patient. I would definitely, if the patient hypo, I will go for a bronchoscopy for this patient first, send for the lower respiratory tract biofire to rule out a atypical viral pneumonia, then send for PCP staining and the PCR, quantitative PCR for that.
Okay, thank you. So as per the ARDS net criteria from the Berlin's definition and the modified definition 2 years ago, no doubt about it that this patient has got severe ARDS. The PF ratio was less than 100, patient got intubated, proned, could not maintain on prone, hence we actually retrieved this patient from a peripheral, from other hospital, and the bronchoscopy was indeed done by the other hospital just before being retrieved, as well as we repeated a bronchoscopy with us, and both of them showed PJP infection. He was profoundly hypoxic. On the way from the hospital to our ICU, we had an opportunity to do a CT scan as well. Dr. Pai or Dr. anybody would like to describe the CT?
Yeah,
That's one relevant picture I've got, not too many.
sort of confirms the diagnosis of a PCP. You're seeing diffuse interstitial pneumonia interspersed with a lot of multiple small cysts in both lungs, which are more predominant on the left side. And this is very typical of a pneumocystis carinii pneumonia infection.
Yeah, so I believe that we need to keep up a little open thought about PCP infection. It still has a very profound effect on the patients. And as we could see, this guy unfortunately landed on the ventilator and then had to be taken on ECMO. So hypoxia, which is disproportionate, shortness of breath may not be the first sign with which the patient would come in always. They would just have hypoxia, and if they are having hypoxia, start thinking of patients if they are immunocompromised, the PCP infection is a possibility. Let's move on to the next case in the interest of time. 62-year-old, diabetic, well controlled, otherwise fit and healthy, presents with cough and saturation of 90% on room air. Just the deja vu of COVID, where we would have a happy hypoxia. This guy walks in with no respiratory distress, but as soon as the pulse ox is put on, saturation is 90%. And he needed only 2 liters of oxygen via nasal prongs to improve the saturation to 99%. He was breathing at the rate of 21. His heart rate was around 88, 89 beats per minute. Regular, blood pressure was normal. He had no other symptoms, just a bit of cough and saturation low. Again, this is a patient who actually came in on a background of cirrhotic liver disease. So, any thoughts on this, sir?
So again, using multiple patchy consolidations, predominantly in the right lower lobe. You're also seeing a fairly large consolidation in the left upper lobe. So we have a multifocal consolidation. There is no pleural effusion or a pneumothorax. There is mild cardiomegaly with an unfolded aorta. The bony thorax appears normal, and both domes of diaphragm are normal in position.
So, Dr. Bindru, patient not that hypoxic, not that tachypnic, but still has hypoxia. Walking pneumonia? Any thoughts on this pneumonia? What's this terminology of walking pneumonia which is being talked about?
Atypical pneumonias can present like this. So there's a definite discordance between the clinical presentation and the radiological presentation. So this is very important to learn that a patient can come with slight respiratory distress with a bit of hypoxia, but will be having a bad chest X-ray picture. So atypical pneumonias can cause this type of picture. A lobar pneumonia, bacterial pneumonia can be, the patient will be very hypoxic with that. So atypical pneumonia.
Any thoughts from your side, sir?
I agree with the panelists. Usually, typical presentation of a pneumonia, patient presented with hypoxia along. Again, he has diabetic. Differential diagnosis, again, first comes is pneumonia and follow.
Okay, any value, Sushil, of doing a biofire? It seems to be the test which everybody wants to do. Very quick analysis of viruses, bacteria, and fungi. Any value of adding this to this patient's upper respiratory tract or lower respiratory tract biofire? Sushil?
So I think that the upper respiratory tract will be more useful in patients who have got symptoms of upper respiratory tract and they are having, we think of some viral etiology. Atypicals, normally we should do a bronchoscopy, do a BAL, and then send the lower respiratory tract sample for the biofire to find out the atypicals as well as the viral infections. Upper respiratory tract sample for atypicals is not a good idea to do it.
Absolutely correct. If you have a suspicion that this is an atypical pneumonia, no point in sending any upper respiratory tract samples. It's not going to help you diagnose it. If you have a good lower respiratory tract sample by either induced sputum or doing a proper bronchoscopy, then yes, you may get a diagnosis, but then you may get a diagnosis on normal culture as well as the things. Third case, day 25, post-liver transplant, complicated by CRE, sepsis, MDR, Klebsiella, Candida auris in urine, hypoxic on HFNC 0.3% FiO2. This is the chest X-ray of the patient.
Yeah, again, almost similar findings as compared to the previous film. Large consolidation involving the right mid-zone and the lower zone, and patchy consolidates in the left mid-zone. So again, a widespread bronchopneumonia, more pronounced on the right side. The pleural space on the right side cannot be well commented upon because of the consolidation. though an underlying pleural effusion cannot be ruled out. I can see a tracheostomy tube in position, otherwise nothing relevant in the plain films.
Any other thoughts on that?
What was the history?
Either of you is fine. Any other thoughts on that?
Post liver transplant.
Sorry? Day 25. Day 25. Day 25.
It has consolidation on, involving both the lobes.
So yeah, see if you see the right lower lobe is consolidated and you're seeing a lot of fluffy nodular opacities in the left lung. When you see a situation like this on a plain film or on a CT, one would obviously think of atypical pneumonia. Obviously, one of them would be a fungal infection. And that is one thing that one needs to rule out in such a patient.
So yeah, in the setting of not an immediate transplant patient is on immunosuppressive therapy with these shadows, which where you can see the some lobulated forms in the left lung, mostly the left upper lobe. See, I would think more of a fungal infection in this case rather than a bacterial infection.
So bronch was sterile. Bronch is sterile. There is nothing which grew on the bronch.
Okay, if the bronch is sterile, then I will think of some inflammatory conditions. A BOOP can be a condition which can occur in patients, post-transplant patient, which is a bronchiolitis obliterans organizing pneumonias. They can present with these ground glassing and shadows. And so mostly peripheral shadows, because most of the immunosuppressive drugs can lead to BOOP, and that can be a finding in these patients.
Yeah, also fungal pneumonias can be deceptively difficult to actually diagnose. The bronch may still have nothing growing up, but you need to suspect of a fungus, especially because this patient had a Candida auris growing in the urine. But again, Candida auris pneumonia, I've rarely seen one, but yes, you need to keep your thought process open for a fungal infection. Just last spot diagnosis, and that's my last case. Anybody who can talk about it is fine. Any of the three panelists.
Okay, this is a pediatric chest portable film, and one can observe that the entire left hemithorax, or rather the left lung, is completely opaque. You can see patchy consolidation in the right upper lobe and a part of it in the right lower lobe as well. But what is very important and which needs to be picked up is the position of the endotracheal tube, which is seen completely in the right bronchus. So the endotracheal tube has been placed into the right bronchus, as a result of which the entire left lung is consolidated. There's a collapse of the left lung. What is very important, and that is what I keep telling our residents in training, that once you pick up a finding like this, it's the job of the resident doctor or whoever is seeing the film to call up the ICU consultant immediately or the ICU treating doctors and tell them that there's a problem. This film needs to be, you need to reposition the tube to a position just above the carina and get both the lungs well ventilated. And very importantly, it's just not picking up this, it's also telling them that repeat the film after you position the tube, so that you're seeing that the lungs are equally ventilated, and that becomes the crux of the diagnosis here. So endotracheal tube which has been placed in the right bronchus, very important for the clinician also to have possibly auscultated this patient. I'm not the person to be telling it, but that could have been easily picked up on the bedside itself.
Absolutely. I feel that this patient should not even have had an X-ray like this. That should have been picked up clinically. Clinical medicine gone for a toss. Nobody auscultated the patient, wanted an X-ray to confirm a tube. Thank you very much. Thanks for the panel, and thank you very much, crowd. Bye-bye.
We have time for a few questions for the previous session as well as this one, if anyone would like to come ahead.
Hello. I have a question.
Yeah, okay. Yeah. All right. So then we'll take a quick break for lunch.
I have a question. I have a question.
Sorry.
So, good afternoon. I'm Dr. Ajit. I want to know, I have a question from Dinesh sir. If the patient is on, as you mentioned, CLD with the TB, and then if he's having a HIV also, so what about that? In that case, some of the ART also causes hepatotoxicity, such as dolutegravir.
Absolutely. That's more complicating the whole scenario. So we should involve the infectious disease specialist, and most of the HART drugs interact with anti-TB and more hepatotoxic as well. So once again, as I say, like we need to monitor them very closely. You may have to use non-hepatotoxic second-line agents for the tuberculosis treatment, and monitor the LFTs very closely. Then, see how they progress. It is a very complicated situation actually.
So in this case, first we should treat the HIV only, and then we should start with the ATT.
Yes, yeah. So we
Because
need
of
to,
virus.
yeah, and then the tuberculosis therapy you can start. You can start concurrently as well, because you're not going to use that toxic hepatotoxic drugs here.
The second doubt what I have is, you mentioned like to start ATT either on the one drug regimen or the two drug regimen. So like whenever we start ATT, so it is per kg of body weight. What about in this case? Shall we give per kg, or shall we start with the low dose only, whether two drug or the one drug, and then increase the dose?
Depends on the severity of the disease. So if the cirrhosis is quite advanced, then start at a staggered dose, start low dose, see the tolerability, and then you can increase the dose if tolerated. Yeah.
Okay, thank you.
Can I have a question to Dinesh sir as well? Just after what time after transplant do we restart ATT when we have transplanted for ATT-induced ALF?
No, that's a very good question. So it's not you should start immediately post liver transplantation. First, optimize the graft function. Make sure you have achieved some standard tacrolimus dosing. Make sure they are out of the ICU, out of the ward, and then closer to discharge. Maybe 2 weeks to 4 weeks, preferably 4 weeks. You can actually restart the drugs one by one.
One by one.
Yeah, because they also
Patients are
interact.
quite reluctant to restart because they have undergone, they are young kids, 20, 25, they undergo a transplant for ATT-induced ALF. And when we talk about reintroducing ATT after the transplant, they are very skeptical and they say now they are completely fine because patient remains asymptomatic.
No, in fact, they tolerate better. Absolutely. Yeah.
Dr. Dinesh, actually, I have a follow-up to that question. I just wanted to know, so if there is already ongoing AKT, would you stop it and then restart it?
That's right. So if they develop acute liver failure, you need to stop the anti-tuberculous therapy, treat the acute liver failure. Most of the time they may improve without the need for liver transplantation. But if you look at the King's College criteria, if you have drug-induced liver injury, the prognosis is literally very poor. The spontaneous recovery is less common, particularly if you have non-paracetamol ALF. So if they don't recover, then you should offer transplantation, and then we can treat the tuberculosis later. Okay. And many times, if you see it's empirical anti-tuberculous therapy. So we've seen that there is absolutely no evidence of TB anywhere actually. So that's we have seen.
All right, I think we can take a break here for lunch and we'll see you back here in Hall A at 2 p.m. for our next session on HCC.